With all these new reforms, I think everybody is so mystified, still unclear. Can you shed a light on what is happening and how things are going to be?
I'll make a couple comments on that, but I think healthcare right now is going probably through the most biggest transformation it's gone through in this country since 1965. In 1965, that was the birth of the Medicare program for seniors. But what's different in this healthcare reform, it's not just for seniors, it's touching all aspects of our population. So regardless of your political persuasion, everyone likes the idea of how do you give access and healthcare insurance to the population as a whole. So no one's against that concept, but the challenge is, I think right now, is what we've ended up doing is we've created a very complex system right now with, I think, people thinking, once I have insurance and I've signed up for something, I've had a pre-existing condition and haven't been able to get it, I'm automatically enfranchised and I have access to health care. And here's the tricky part that's happening with healthcare reform. To pay for it, they're actually transferring more of the cost to the patient and their family right now. So as people get access to more health care, even people that have pre-existing conditions like diabetes or they've had cancer, they have high blood pressure, they're going to see when they finally sign up for insurance through the exchanges and they look at that insurance card that they get, they're going to find they have co-pays or deductibles and higher out-of-pocket costs. And I think the challenge that we're going to have for both doctors' offices and hospitals, I think a lot of people think the good news that we're expanding the healthcare insurance availability for people, but a lot of people I think it becomes, once I get that card, it's like my own credit card and I have access and I can get any access I want. So that out-of-pocket cost is going to be a very challenge for people. And what the reason the government wants to do that is they want to expand insurance more, but they also want people to be more cost-conscious on their health care insurance. And the only way to do that is to have a little bit more out-of-pocket cost as they expand access to health care.
But that would limit the services or doctor visits, yeah? If they have to pay from, they have to think twice before going to a doctor.
Well, I think I think what they're trying to do is to definitely make people pause before they rush for access to health care. But you've had a whole segment of our population that have had health insurance because their employers have paid most of the premium. So they've had that ability. Then you've had a segment of our population that's been generally healthy and they've been able to buy their own insurance. The good part of what's happening now is are those people that either did not have insurance through their company or they've had pre-existing conditions where they couldn't get insurance or it was so expensive they didn't have access for it. So I think that's the good news with all this insurance expansion. But what we really need to do is to get people focused more on, once they have insurance, learning how to access their primary care physician. So a lot of care and screening is being done outside of the high-cost emergency room or hospital setting. And that's somewhat of an educational process for people, because a lot of people that haven't had insurance, they still look to the emergency department as almost like their primary doctor, and that's where they go.
I found because I had a couple of colleagues saying that my child was sick, I mean flu type, and we went to emergency. And I know that that is very, very costly to go to emergency.
It is, and that's all embedded in the cost of health care. But it's also an educational process to get people to, and so as some of the medical groups and primary care physicians, they're coming up with more extended office hours because people work during the day. So sometimes, if someone has a health problem, you need to see someone at 6, 7, 8, 9, or 10 at night.
That's right.
So urgent care centers or doctors' offices, I think, are going to expand. And I think with this expansion of insurance to so many more people that didn't have it, there may be actually a primary care doctor shortage. And so you're going to see more nurse practitioners and physician assistants that are trained to do more primary care so people can get access but at a lower cost setting but still get the information they need. Or sometimes the prescription they need.
Mr. Ivy, I know that the hospital has been among the 50 best hospitals nationwide for the last 5 years.
Correct.
I mean, this is something that we should be very proud of. I mean, we living in Glendale, we have a hospital that for the 5 years has been among the best 50 hospitals. How do you get this award? I mean, what is the criteria for getting this award?
What they say in the industry right now, and this is because a lot of the healthcare is now being underwritten by government programs, is they want to pay for value, just not service. And so they define value, and if you take someone that's had a heart attack or has pneumonia or has heart failure or diabetes, they've come up through a lot of the universities with a lot of basic, what I would call documentation and initial treatments that must be provided for those different types of diagnoses. And they must be provided in the right setting at the right time by the right practitioner. And those are the indicators they track. And if you do very well and are in the highest percentiles on those, and they're tracked at a governmental level, then you end up moving to the top or more of the elite in terms of your outcome on those measures. And that's what's tracked, and it's done over a lot of patients, so it isn't based on a small sample, but it's a lot of patient encounters, and we've done quite well on that over the years because we do a lot of basic primary care medicine in the hospital besides some of the special programs we talked about a little earlier.
Yeah, absolutely. And then you have a very good oncology, hematology, Dr. Yukar, that again, he's on our board.
Yes.
And Dr. Yukar, I know that he's got wealth of experience in this field. And then your colon cancer center, the recent one.
Correct. Yeah, obviously we have some very strong oncology specialists. Dr. Yukar is one in his group there, and he's been there a number of years. He's trained out of UCLA, and so they also participate in a lot of clinical research protocols. So some of the cutting edge therapies for chemotherapy or other types of adjuvant therapy, they call it. He's very conversant, and some of our oncologists on that. So that's very important. The colorectal Cancer Institute is very important because colon cancer is a very high frequency cancer diagnosis.
Absolutely.
And it's very treatable. And that's where I go back to, if people know how to access their primary care physician, and there's some basic screening tests that you can do that are non-invasive for colon cancer, and based on those findings, it's a very treatable cancer if caught early. And that's one of the key focuses of the Colorectal Surgery Institute at the hospital.
I did my colonoscopy previously at the hospital in Pasadena. And then this time I said, well, no, I'm going to my community hospital. So I did it at Glendale Memorial Hospital, and it was very nice, especially those warm blankets that they use at the hospital, and the service was excellent.
What we've done is we've actually built, we call it a colorectal clinic, and we have actually we have also a special clinic for OB that's on the hospital campus. But what's nice is in the clinic setting, you have the same physicians you'd see in the hospital, but there's a broader array of procedures they can do in a clinic environment. It's a little more comforting and less threatening to patients than having the hospital institutional look. And it's only if you need hospital services that you'll come to the hospital. So a lot of people like going to clinic settings because it's a little bit more family-oriented, less institutional, and I think you can have some of the touches you talked about at the clinic setting.
Absolutely. It was so warm, nice, and it was so quick. So I didn't even wanted to take a day off because I was feeling so well, but then I used the excuse not to go to work that day. Also, I think it's very important for especially the cancer patients and people with special needs like diabetes and all that, they know that you also have support groups. I know that you have a very good breast cancer support group at the hospital. And I gave a talk once to the patients, but also you have kind of a nutrition-oriented classes organized as a hospital.
That's true. I think what's never changed is when people get a cancer diagnosis, it's not only, it makes you pause, but sometimes when you begin the care process, you and your family can't process the information because that cancer is sort of a fearful diagnosis.
It's shocking.
So sometimes
Yes.
having these support groups, these educational groups, it helps people, what I call, navigate through the care process. Because with cancer, it's usually not one doctor you see. And you may you may see oncologists, you may see surgeons, you may see people that know radiation oncologists, you see nurses, you see nutritionists. So you need the support groups and the education piece to navigate, so not only your fear is lessened a little bit, but you get a lot of the questions you're answered. And sometimes physicians, as busy as they get, they obviously, they're managing your whole continuum of care, but you really need education and navigation along the way, and that's what we're trying to provide for people that go through the cancer treatment process.
And sharing experience is very important in the support groups, especially when it doesn't come from a doctor. It comes from a patient who has gone through it. So two patients talking to each other. So the adverse effect of anything it looks a little bit more relaxing when we share our pains.
That's so accurate. The same
Yes.
thing happens with people. We also have that with our cardiac program with people that have had open heart surgery. And when you can go into a support group, and some people are shy or they're embarrassed that they've had a health problem, so you need to sort of pull them out and communicate. So they communicating your feelings to doctors is not how people view physicians. But in support groups, when you can suddenly say, I know exactly how you feel. A year ago I had open heart surgery, or I've had your cancer diagnosis, but I'm 6 months into my treatment. The humanistic connection between and among people, you really can't accurately quantitate the value, but because healthcare really, it's the human experience you're going through.
Yes.
And you never can lose sight of that, that you're treating people. And I always think that's where I take my role seriously in a hospital, working with all the professionals, is we're actually treating people when they're in the most vulnerable stage of life.
Yes.
When you don't feel well, you're not in the best position to make decisions or sometimes even articulate your feelings. So you need to have a care setting that comes around you,
yes,
where you speak. You're not afraid to be vulnerable, and that's when you're not afraid to be vulnerable, you're most open to therapy and I think the curative process.
Absolutely, and then you know that you are bonded with the right people, surrounding your treatment, and that's the key for any successful treatment. Unfortunately, we are running out of time, but coming back to our bone marrow and Glendale Memorial, I think we are so proud, we are so grateful. I don't think I can find words of gratitude enough to describe how instrumental the hospital has been in building up this project and from day one. And I'm so glad that it continues to do so. I think I want to ask on behalf of everybody, to thank all your administration staff, to thank Rima, to thank Mary Philippian, who newly joined,
yes.
And special thanks to, of course, my dear friend David Moss, and all your hospital staff for their continued support, all your nurses, because they also come and help us with the phlebotomy and recruitment. So it's a wealth of knowledge, experience, and mentorship that we share with each other, and thank you so much.
Well, I thank you, and I do want to comment, sort of congratulate you and all sort of the founding fathers. This 15 years is an incredible milestone.
Absolutely.
And I wanted to mention, too, to the broader Armenian community, one of the things I want to bring in, not being of Armenian ancestry, but being lucky to travel the world a lot, that I'm trying to teach everyone in our organization that when you talk about the Armenian culture, you need to be realized you have people that have their ancestry could be Iran, it can be Syria, it can be Lebanon, it can be Armenia, and Africa. And so there's a cultural diversity there, but that's kind of the exciting part about Glendale. It's the exciting part about healthcare in Los Angeles, cultural diversity and connecting with people is what it's all about, and that's part of our mission of the hospital. But congratulations to you and your group.
Thank you very much, and I think you have achieved your mission. Thank you very much, Jack, for coming.
Thank you.
And we see each other sooner, but definitely on May 3rd on our walkathon day.
Absolutely.
Thank you very much. Thank you. Սիրելի հայրենակիցներ, դժբախտաբար մեր ժամը ավարտեց, բայց այսպիսով մենք ավարտում ենք մեր այսօրվա հարցազրույցը։ Մինչև գալ անգամ սեր ջուն ձեզ։